5, 4, 3. Thank you for the honor of the invitation. I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and I'm going to update you about what we're doing today in acute myeloid leukemia at our institution. As you know, in acute myeloid leukemia, deciphering the genomic landscape has allowed us to investigate prognostic factors, but also to develop targeted therapies. Here you see that FLT3 mutations occur in a third of the patients, and now we have FLT3 inhibitors that could help them. But also IDH mutations occur in about 20%, and here's where IDH inhibitors could work. 5, 4, 3. Thank you for the honor of the invitation. I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and I'm going to update you about what we're doing today in acute myeloid leukemia at our institution. As you know, in acute myeloid leukemia, deciphering the genomic landscape has allowed us to investigate prognostic factors, but also to develop targeted therapies. Here you see that FLT3 mutations occur in a third of the patients, and now we have FLT3 inhibitors that could help them. But also IDH mutations occur in about 20%, and here's where IDH inhibitors could work effectively. So this is how we apply today the molecular studies to the treatment of patients with FLT3 mutations. We add a FLT3 inhibitor, and the favorite one is gilteritinib at our institution because it's a third generation more effective FLT3 inhibitor. For the IDH mutations, you can add either ivosidenib for the IDH1 mutations or enasidenib for IDH2 mutations. Among patients with NPM1 mutations, they are highly sensitive to cytarabine, so we try to add the Ara-C in the setting. P53 mutations are still difficult, so we always refer them to transplantation. And then I'll show you at the end the potential role of the new menin inhibitors in patients with translocation 11q23. Since 2017, we have 9 agents that have been specifically approved for acute myeloid leukemia, and the 10th one, which is oral decitabine, approved for MDS and CMML, but which at MD Anderson we use as an alternative to the parenteral hypomethylating agents in acute myeloid leukemia. So you see on the list, the most important one is venetoclax. I think it's really a breakthrough, and I'll show you that it's not only a breakthrough for the older unfit AML, but perhaps for the younger ones. You have 2 FLT3 inhibitors which are approved, and we prefer gilteritinib, but midostaurin is also available. The next 2 are enasidenib, ivosidenib, which are the IDH inhibitors, and then the oral hypomethylating agents. And I'm going to make the point at the end that oral decitabine and azacitidine are very, very different drugs. You cannot use them interchangeably. Let's start with the most curables of the leukemia. So acute promyelocytic leukemia, as you know, we started treating them without chemotherapy since 2000, only with atraarsenic trioxide, and the addition of gemtuzumab if there's a high white cell count or if they persist to have PCR positivity 2 to 3 months in remission. And this is the data from our institution where we show that we can cure almost most of the patients with the use of atraarsenic trioxide without using chemotherapy. And this is across the board of all the age groups, and we have over 250 patients. The second highly curable category is core binding factor leukemia, so inversion 16 or translocation 821. Here we use the fludarabine high-dose Ara-C with gemtuzumab. We consolidate with fludarabine Ara-C for 3 days for 5 consolidation courses, to which we add gemtuzumab in 2 or 3 courses. In 2010, we lost the use of gemtuzumab and we replaced it with idarubicin, and the results are worse. So really, fludarabine, Ara-C, gemtuzumab, or the flag gemtuzumab is the better approach. And here I show you the data since 2010. So again, an estimated 10-year survival in excess of 80% when we use this strategy. And this slide shows that when we use the idarubicin instead of the gemtuzumab, we lost a little bit on the relapse-free survival curve. So we went back to using gemtuzumab as part of the flag regimen. Now, I mentioned that gemtuzumab is useful in APL and in core binding factor leukemia, but the French have just published in Blood that it may have a value in additional subsets, such as patients with FLT3 mutations and RAS mutations and NPM1 mutation. The problem is how to combine gemtuzumab with venetoclax, because we value venetoclax as a drug that's more useful, and we're using it in combination with intensive chemotherapy, which I'll show you next. So now we're going to come to the treatment of the other acute myeloid leukemia, so patients who do not have APL or core binding factor leukemia. And as you know, the standard that has been accepted by many for the past 50 years is a 3+7 induction, one high-dose consolidation, allogeneic transplantation if possible, if not, a total of 4 high-dose Ara-C consolidation and no maintenance. If you accept this as a standard of care, I am showing the results on this slide. So on the left side are the patients who are younger. At best, you can probably cure 35 to 40% of the patients. And on the right side are the older patients who can still receive 3+7. And here the cure rate is under 20%. So we can do better in the younger patients with FLAG-IDA venetoclax, as I'll show you, and we can do better in the older patients with the triple nucleoside low intensity therapy, which I'll show you at the end. So this is the data from MD Anderson. So since 2010, our estimated 5-year survival is close to 60%, and this is because we do not accept 3+7 as a standard of care. We try to do better than that. In the older unfit patients, we are improving the survival, but still we're not doing as well. And I do not show the data since 2015, where we are using the venetoclax in addition, and I'll show you the data at the end. So what do we do at MD Anderson? In the younger patients, we either use FLAG-IDA or CLIA with venetoclax. We add the FLT3 inhibitors as indicated. We still try to take the patients to transplant. If not, they receive the same intensive chemotherapy for 6 cycles, and then everybody gets a maintenance for 2 years. In the older patients, we cannot do the intensive chemotherapy, so I'll show you the regimen with the triple nucleoside analog therapy, cladribine, low-dose Ara-C, azacitidine with the addition of venetoclax. Again, we try to take them to transplant or do maintenance therapy.